Michael Smith, and we're grateful that you've taken the time to join us for this SCCT hosted HeartFlow sponsored webinar on unlocking the potential of FFRCT, coronary CTA, and the role of the technologist. I'm Michael Smith of HeartFlow's Medical Affairs and Education team, and I'm joined today by two of our CT application specialists, Stefanie Carpenter and Amanda Cunningham. So we're going to jump right in with Amanda.
Thank you, Michael, for that introduction. What is fractional flow reserve, or FFRCT? FFR is a test that has traditionally been performed invasively in the cath lab to determine the functional significance of a stenosis in the coronary arteries. During invasive FFR, adenosine is administered to achieve the maximum hyperemic state. A pressure wire is then placed in the coronary arteries where a value is obtained just distal and proximal to the lesion of concern. These values will determine the functional significance of the stenosis. FFRCT is a non-invasive, personalized 3D model of the coronary arteries. The images are acquired from a standard CT coronary scan, then sent to HeartFlow for individual analysis. The AI algorithm and human interaction take into account anatomy and physiology to determine if a patient has narrowing or blood flow blockages present in the arteries. A standard coronary CTA is performed and a select set of axial images will be uploaded to HeartFlow. HeartFlow's proprietary software uses a combination of AI-driven algorithms along with certified analysis who offer a human touch element to each personalized 3D model. Physicians then can use the data from the HeartFlow's analysis and 3D model to help assess vessel by vessel if sufficient blood flow is getting to each section of the heart. Now we will play the video.
My grandfather died from a heart attack. My father had a heart attack when he was 70. That kind of put my heart disease on the radar screen for me.
When you are experiencing symptoms of coronary artery disease, you want quick and accurate answers.
I had a typical stress test, and I came through that with flying colors. There was a side of me that said, okay, well, I'm clear. There was another side of me that said, you know, there's really probably something more here, and we need a more definitive test.
The challenge is that the most commonly used tests, a SPECT stress test and an exercise stress test, often don't provide enough information for a diagnosis. This can result in delays for additional testing to be completed that oftentimes ends up being unnecessary, or a completely misdiagnosis altogether with potentially fatal results. But now there's a better way of diagnosing coronary artery disease, a non-invasive test that provides your physician with more accurate information for understanding your condition. Introducing the HeartFlow analysis. The process begins with a standard, non-invasive CT scan of the heart. If your physician determines that no disease is present, no further action is needed. If the CT scan shows disease, your physician can send the scan to HeartFlow, where a color-coded digital 3D model of your coronary arteries is created. The HeartFlow analysis shows the impact that blockages have on blood flow to your heart, information that otherwise would only be available with a riskier, invasive test. This personalized model of your coronary arteries provides your physician with the detailed information needed to better understand the severity of disease and determine the next step in your treatment plan.
I think that patients derive a greater sense of confidence when they know that you've looked at their arteries or they've looked at their arteries rather than just a bunch of squiggly lines on a treadmill test.
The HeartFlow analysis was the only test that was done on me that was truly definitive in defining both the amount of blockage in my coronary arteries and the flow restriction. No one wants to go around wondering whether their blockages are going to lead to a heart attack, and having this all behind me has reaffirmed my optimism.
Welcome to the modern way of diagnosing coronary artery disease, the HeartFlow analysis.
Coronary CTA images shows anatomical findings. Treadmill, stress, echo, MRI, and SPECT imaging demonstrate functional findings. FFRCT combines both anatomy and function to provide a more complete picture of the coronary artery disease. In these examples, coronary CTAs were ordered based on patient symptoms presented to their physician. Based on anatomical results, both patients had a high-density calcified plaque with 70% stenosis in the proximal LAD. Additional testing was recommended to evaluate the hemodynamic significance of the findings. Functional data could be assessed invasively with FFR in the cath lab or non-invasively by submitting the coronary artery images to HeartFlow for FFRCT. Here we can see the mismatch between anatomical and function. For the patient on the top, the anatomical stenosis is again visualized by invasive angiography. But when the FFRCT is performed, the results measured above the 0.8 threshold, indicating intervention is not necessary. Conversely, the patient on the bottom row would be considered positive with a flow limitation due to FFR and FFRCT values being less than 0.8 threshold in both instances. FFR and FFRCT measurements correlated well. Anatomy and function are different. One method of reporting the accuracy of a diagnostic test is the AUC curve. AUC stands for area under the curve, where the test with the largest area underneath the curve is best. As shown, coronary CTA combined with FFRCT delivers best per vessel performance than any other non-invasive test, such as PET or SPECT imaging. The Pacific FFRCT sub-study in NXT reported FFRCT diagnostic accuracy of 87 and 86%. Optimizing CCTA best practices, contraindications for FFRCT, patient prep and selection are crucial roles technologist fills. Here we can see an example of a HeartFlow PDF that will be sent back to your PACS or alternate EMR destination. You can see patient information on the top and a quick overview of the findings. Next, a quick look at coronary artery with triangles showing stenosis and where it falls on the FFRCT scale. Finally, an image of the patient's model with lesion-specific pins placed. Each pin place is where HeartFlow observed a 30% or greater decrease in lumen diameter. The next page shows coronary and lesion-specific pins placed in the most distal or nadir FFRCT values for the vessel. The HeartFlow analysis has been studied in patients with prior PCI, but FFRCT values have only been validated in vessels without metallic stents. For this reason, when submitting studies without prior PCI, there are 3 instances where the case will be automatically rejected for analysis. First, when a metallic stent is present in the left main artery. Next, in the presence of a left main coronary artery stenosis that is greater than 30% and 1 or more metallic stents present in the left system. And last, when there are multiple vessel systems with stents. If a patient has a metallic stent present in one vessel system, as this patient does in the circumflex, the vessel will be gray in color and no FFR values will be provided. The FFRCT will be provided the other 2 vessel systems that do not have stents present. There are other instances for automatic rejections, such as patients having previous bypass surgery. Because the validation of FFRCT has not been completed on these types of patients, HeartFlow is unable to process. Some fistulas can affect physiological changes in pressure and flow. For this reason, we cannot process cases with fistulas that is greater than 1.5 millimeters in diameter. HeartFlow recommends that your site follow the SCCT guidelines for performance and acquisition of CCTA imaging. The Society of Cardiovascular Computed Tomography is an international professional society devoted to cardiovascular CT. They develop evidence-based guidelines and expert consensus documents. This journal documented article will be referenced often during this presentation. If you would like to request a copy of the SCCT documents, you can reach out to your CT applications representative from HeartFlow or send an email to support@heartflow.com.
Here we see examples of excellent, satisfactory, and poor image quality in CCTA images. Following the SCCT guidelines is essential to achieve sufficient image quality necessary for HeartFlow to model anatomy accurately. With the appropriate patient selection, preparation, and protocols, excellent CCTA images can be obtained. This allows HeartFlow to provide a clear, high contrast view of coronary arteries and plaque, free from artifacts that affect the visibility of the lumen boundaries. Should a case not meet processing quality criteria, the case is returned with a brief explanation. Recommendations for improvement are provided and can include requests for additional reconstructions of the CT data for resubmission. HeartFlow's acceptance rate for real-world users is greater than 90%. In order to create the most accurate FFRCT model, the image quality of the CT data supplied must be optimized. The scan range must include the entire myocardium, and the exposure factors must be optimized so that the lumen boundaries of the coronary tree are easily discernible. HeartFlow engages with CT subject matter vendor experts to supply recommended acquisition protocols for their CT scanners. These and additional resources are available on HeartFlow website. In addition, your CT application specialist is available to assist you with scanner-specific protocols, questions, and concerns. This is another example of why image quality and correct selection of recon parameters are so important to a HeartFlow FFRCT analysis. In the first example, high levels of iterative recon created a false MLD, or minimum lumen diameter. This modeling of the coronary artery created an MLD and FFRCT values that did not depict the patient's true anatomy and physiology. In the second example, a more accurate representation of the patient's anatomy is depicted. By sending additional reconstructions with a lower, more appropriate level of iterative reconstruction, we see the MLD is more accurately modeled and the patient's treatment courses may be changed dramatically. Submitting multiple phases and kernels is also important for processing for FFRCT. In the example on the left, see how the appearance of the calcium differs depending on phase location, while the example on the right shows how different kernels of the same phase location depict calcium differently. For these reasons, it is important to submit multiple phases and reconstructions to HeartFlow, as different series may provide improved interpretability of challenging regions better than others. HeartFlow is able to process studies with a heavy calcium burden. In this case, the patient had a high calcium score of over 2,000. When looking at the anatomy alone, it was thought this patient could possibly have some significant stenoses. After the addition of functional information, the study was negative for flow-limiting lesions, and the patient was able to be treated with optimal medical therapy alone. Additionally, if you look closely in the MPR sections, you will notice that despite a high calcium burden, the lumen was able to be identified. Lumen boundary clarity is crucial, which allowed this study to be able to be processed. This demonstrates the effect of low kV on calcium blooming. If you look at the image on the left, scanned at 80 kV, proximal to the calcification, there appears to be soft plaque. When the patient was scanned again with 120 kV, the blooming significantly decreased, and there's no evidence of soft plaque. When imaging with low kV, there is a higher chance of providing FFRCT score that could prove to be falsely positive. In reality, the calcium blooming could have been avoided with proper kV selection on the initial scan. With the utilization of appropriate kV, you can significantly reduce the incidence of artifacts and increase the accuracy of FFRCT results. SCCT guidelines state 120 kV is the standard for cardiac imaging. When calcium is present, the use of sharper reconstructions can further identify calcium borders to improve accuracy and reduce discordance. Note the large portion of calcium not seen on the left image until a sharper reconstruction is applied. Cardiac motion is another factor to consider. Having a stable heart rate of 60 beats per minute or less is preferred. When discussing optimal heart rates, the SCCT states that image quality is generally better if the heart rate is less than 60 beats per minute. HeartFlow explored the relationship of heart rate and the rate of FFRCT acceptance. As you can see, there's a clear inverse relationship between heart rate and the likelihood of HeartFlow not being able to process FFRCT. As the heart rate goes up, the likelihood of acceptance for performance of FFRCT goes down. The effects of heart rate variability are demonstrated by slab artifacts. HeartFlow recommends retrospective scanning when heart rate variability is greater than 3 beats per minute. This can help to reduce slab artifacts shown here. In this slide, you can see that the RCA presents differently at different phases. For this reason, HeartFlow recommends sending multi-phase data at higher heart rates. If the patient's heart rate cannot get below 60 beats per minute, open up the scan range from 40 to 80%. Submitting systolic and diastolic phases in patients with heart rates greater than 60 beats per minute can help improve site's acceptance rate and processing for FFRCT. When the patient has high heart rate variability, phase percent may not be the most accurate because of the irregularity in the distance between R to R peaks. In this example, you can see the 75% phase falls in a different location on the 74 beats per minute heart rate than it does on the 60 beats per minute heart rate. This will cause misregistration on the CT images. When possible, using millisecond reconstruction can often alleviate this artifact. As you can see in this example, reconstructing at -250 milliseconds aligns the reconstruction window on the front half of the P wave on all 3 heartbeats. Reconstructing your images at the same location in each heart cycle can help to correct misalignment artifacts. HeartFlow recommends following SCCT guidelines for the use of nitrates. Here you can see an example of a CCTA scanned with and without nitrates. Note the significant difference in the length and diameter of the coronary vessels. FFRCT values could vary significantly if nitrates are not administered properly. For maximum vasodilation, SCCT recommends scanning 5 minutes after sublingual nitrates have been dissolved. Contrast enhancement is essential to differentiate between the small structures in the heart, define the lumen boundary, and view plaque within the coronary arteries. This is also important for HeartFlow analysis so that accurate segmentation of the lumen can take place, and in turn, quantitative analysis can be provided. Continuing to follow the SCCT guidelines, it is recommended to use an 18-gauge angiocath in the right AC whenever possible and inject between 5 and 7 mL per second. Here is an example of poor contrast injection on the left and ideal example on the right. On the left image, there is an excess amount of contrast in the right atrium, possibly caused by scanning the patient too early or injecting the contrast at a low injection rate. This has caused streaking artifact, which is affecting the visibility of the right coronary artery. On the right image, the contrast has been flushed through the right side of the heart and is enhanced nicely in the left ventricle, along with good opacification in the coronary arteries and aorta.
According to the SCCT guidelines, the scan range should cover the whole heart from the inferior carina through the apex. This range is typically 12 to 16 centimeters in length. To ensure optimal image quality and appropriate acquisition, it's important to have correct patient and ECG lead positioning prior to the scan. The patient should be isocentered to ensure suitable dose modulation. The entire myocardium must be included in order for HeartFlow to be able to process the case. When dealing with misalignment artifacts, if the lumen boundary is disrupted but there is no data missing or disease being impacted, HeartFlow may be able to analyze the case. In these examples, you can see that the diameters of the proximal and distal vessels are similar, as well as having no missing data or impacted disease. Therefore, would be suitable for FFRCT analysis. Visualization of the luminal boundary is crucial for HeartFlow analysis. In these examples, due to high levels of noise, accurate determination of the luminal boundaries would be difficult. For this reason, HeartFlow is not able to process cases with severe noise. HeartFlow has the potential to revolutionize and change the way practitioners diagnose and treat coronary artery disease. Utilizing SCCT guidelines gives your patients best opportunity for processing with HeartFlow. As CT technologists, you play a pivotal role in optimizing excellent image quality. Should you need assistance, your local CT application specialist is available to help with protocol optimization and CCTA best practices. Thank you.
Thank you, Stefanie and Amanda. That was a fantastic overview. We are excited to take the questions from the group now. So if you have any questions that came up, please include those, just put those right into the chat, and we will start taking those now. Thank you so much. So looking at the questions in the chat here, it's awesome to see engagement from the group. So we'll start with this one for you, Amanda. How about we do that? It says, how long does sublingual nitro last in your system before it is ineffective?
Awesome, thank you. It lasts up to 30 minutes in your system.
Okay. And then to Stefanie here, how about this one? What do I do if I cannot get an 18 gauge angio in my patient? That's sort of the next option there.
Yeah, so if you're unable to get an 18 gauge angio, the next option that you can try is to use a diffusix catheter if it's available at your health system. A 20 gauge diffusix catheter is going to be able to accept flow rates up to 10 mLs per second. So if you can't get the 18, the 20 is kind of the next best thing.
Maybe we do this one here. So back to sublingual nitro here. So we'll go back to you, Amanda. When is it the best time to administer those? Do you do that before or after the calcium score? What do you think about in terms of timing? How do you sort of play that out? Just given all the time constraints that are realistic today in the lab.
Yeah, absolutely. So it's best you can do the test injection. You can give your patient breathing instructions. And then go ahead and give them the nitro. You can do the calcium score, and then you want to make sure that it's 5 minutes after it's dissolved. So by the time you do the calcium score, and you get to the coronary portion of it, it should be about that 5-minute mark where it's after it dissolves. So you just want to make sure it's fully dissolved before you proceed.
Okay. I did see there was a hand up, but I don't know. So if that person wants to just drop their question in the chat, we're happy to take that too. Maybe we already addressed it here. Another one for Stefanie. Let's go to you on this one. Just talking about phases, right? Obviously that can be a complex issue. So what are the best phases to submit to HeartFlow, especially when your patient has an arrhythmatic heart rate? So I think maybe what's best in general, and then how do you think about in that certain situation? How do you handle that complication?
Yes, so if they have an arrhythmic heart rate, typically retrospective scanning is going to be the best option for that. We like to have multi-phase data So if you can send systolic and diastolic phases, so like 40 to 80 by 5% intervals, and then possibly millisecond reconstructions as well, if you have that option on your scanner. Not all scanners have that available, but if you have a millisecond reconstruction.
Awesome. So obviously people are pulling a lot of information off of the scanner. Should they just send kind of everything that they have to HeartFlow, or just those few? How do they think about that and just on a standard patient?
So typically 40 to 80% is a good range. They could also potentially, for milliseconds, if it's arrhythmic, like 200 to 400 milliseconds, or 250 to 450. Those are typically good ranges to send.
Okay. And then let me see here. And then just a question about scanners. So what scanners do you find provide the least amount of artifact, and are beta blockers always required with a higher heart rate? So, you know, I'll comment just quickly on scanners, right? We see there's a tremendous amount of great technology out there. The scanner vendors have really moved this technology forward in an incredible way. And we see great, it's always a combination of team and technology, right? We see great teams who make older scanners sing, if you will, just incredible quality. And we also see opportunities with even fantastic new scanners where the teams can do certain things to really bring those to life. But is there anything, as somebody's thinking about how to manage artifact and how to reduce that you would comment on? Maybe Amanda, we'll go to you on that. How do you think about that?
Yeah, you literally said it perfect. So there are lower end scanners, older scanners that they can do great things. You just have to be very vigilant with your heart rate control, but focusing on scanners that probably have better temporal resolution is going to provide better, less artifact, better quality scans. But yes, beta blockers are always needed. Even if you have the latest and greatest scanner, we always like to just reference the SCC guidelines that say heart rates that are 60 below generally have better image quality.
Awesome. And then Stefanie, I'm sure you take this one on all the time in the field, but the range for nitro between 0.4 and 0.8, right? And some practices, some institutions sort of lean toward one, and then others go toward another. How do they think about that? And how much does that jump up to a 0.8 maybe impact what happens at HeartFlow?
So it's not necessarily the HeartFlow processing. What it's gonna have an effect on is the accuracy of the processing. So HeartFlow is validated against invasive FFR. So when the patient goes to the cath lab, they're given IV adenosine, which is going to give that maximum vasodilation. So if a patient either cannot get nitro or they get 0.4 versus the 0.8 of nitro, then we're not going to be comparing apples to apples if that patient happens to go to the cath lab. So what I always tell my technologists is if it's not safe for the patient to have nitro, and or it's not safe for them to have the 0.8 of nitro, make sure that it's documented. And then if that patient ends up going to the cath lab and there's a discordant result, we know why there's a discordance, because again, when they go into the cath lab and they get that invasive FFR, the measurements could be different, and they would skew more towards the positive side on the FFR with HeartFlow.
Yeah, that's a great point there, Stefanie, right? That if those epicardial vessels are not at maximal hyperemia, then we will think that they are on the HeartFlow side, even when they're not. And so we may call that positive, whereas in the cath lab, when they administer nitro and then adenosine to get maximum hyperemia at the microvasculature, they'll see that actually what maximal hyperemia looks like, and it will be greater than what we saw. So yeah, we would call that, that's a false positive that we would be providing back. But yeah, if they know that, they'll also know to maybe think about that the information they're getting back from us has that risk. So, and they can use their clinical judgment there and think about all that information. One for you, Amanda, it says, can we use a central line? So what do you think about that one?
Yes, as long as typically we will say on the end of the IV catheter, it will say power injectable. So it's just very important to make sure that is a power injectable. It'll say 5 to 7 mLs rated, and also making sure you know where, you test it, you know where it was placed, you know that it's, clean and appropriate. So yes.
Awesome. And then Stefanie, this one's specific to the protocol that someone has there. They say, the option to choose a range for heart rate is a standard 20 to 80. We manually adjust. Anyway, we manually adjust and have a protocol on our Siemens Edge Plus to 40 to 70. What happens to the imaging if the heart rate falls outside of those parameters?
Okay, so I'm going to take a guess on this one because I'm not super clear on this one, and Amanda, you can jump in. So I'm thinking that the range that he's talking about is for their dose, so that they're dosing, the range comes up as 20 to 80, and they're manually adjusting it to dose the patient for 40 to 70%. That's what my assumption is. So if the imaging falls outside of those parameters, they're just not going to have full dose, and the image quality will be a little bit less than what it is in that 40 to 70 range. We typically like to have 40 to 80, and diastole happens around 75% in those stable heart rates. So 75% is kind of the sweet spot. So we wouldn't be able to get that 75% if you're doing your full dose from 40 to 70. You'd still would be able to reconstruct it, so it would still be available for you. It just wouldn't have as good of image quality as those other phases have.
That's perfect.
So hopefully that answers your question. And Amanda, are you reading that the same way, or are you reading that differently?
Yeah, that is how I read it. Yeah. If it's a retrospective, they can always recon it. And if it's kind of falls out of that range, it's going to be a little bit noisier. Maybe the image quality won't be as good as it could be in the full dose range.
So another question, how fast, so what does the process look like when an institution says, hey, we do have an existing CTA program, we think our quality could be increased? What does that timeline look like to sort of, I mean, is this, I assume this is not an overnight sensation here, right? What does that process usually look like? What's the timeline, and who do they need within the institution, within the team, to be supportive of those changes in order to make that sort of the new standard of care within their program?
Yeah, I'll take it.
And this is for increasing CT quality, right? This isn't for adopting CT. Okay,
gotcha. We'll definitely need a good champion physician so that they can, you can collaborate and create protocols with a lead tech, a supervisor, any admin would be great as well. And then you can work with one of your HeartFlow representatives, your HeartFlow application specialist. They can come in, they can help you fine tune your protocols, medication protocols, scanning protocols, anything that you need. They're pretty much, we have available to help.
And are those protocols often ones that are there best practices from other institutions that the HeartFlow team brings in and offers, or it's really just that tuning of what they're already doing and getting that to maybe a place where it could be slightly better?
I mean, we can do either one. We do have partner protocols that we've, worked with different vendors. We have partner protocols, but each site is a little different. So some may be a little more wanting to be radiation conscious. Some may want, better image quality. It just really just depends on the site. So we're here to help however we can to enhance image quality.
Awesome. Stefanie, back to you. You are getting all the phase questions today. This one says, do we submit all phases from 40 to 80 or just one systolic and one diastolic phase? How do they sort of think, how much is enough and how much is way too much?
So we typically ask for 40 to 80 in 5% intervals. So that'll usually give our analyst enough to look through. Just one typically isn't going to be enough. If it's a low steady heart rate, one systolic and one diastolic can usually be okay. But if they're scanning 40 to 80, then my assumption is that their heart rate is on the higher side. So yeah, 40 to 80 in 5% intervals is a good amount of series.
Awesome. And Amanda, we'll jump to you with this one. So thinking about 80 kVp versus 120. So if there are no calcium deposits found on a gated preliminary imaging, will HeartFlow accept 80 kVp acquisitions, which would decrease contrast loads by approximately 40%? Right? Would we accept at that kVp? What does that mean for us and in our work?
Yes, we do accept 80 kV. It doesn't have to be the 120. We just want to make sure that if there is any calcium that, it is noted that 80 kV can create that calcium blooming. So we want to create what's the truest data from the raw data.
Okay. No, I think we may be about there. Oh wait, no. So this institution, they say their standard acceptable heart rate for a coronary CTA is 50 to 60 beats per minute, which is fantastic, obviously. And then the question, what is the maximum heart rate that they should cancel, right? If they just can't get below that number. And they say, we've certainly had successful scans at 70. Even so, how high have you seen, I guess would be one way to think about this question, where the scans have still been good scans, right? And we certainly see that. I think the technology does come into play at that point, kind of what's spinning around that patient comes into play at this point. But yeah, how would you take that one, Stefanie? And then Amanda, I'd love your thoughts on that too.
Yeah, so how high should you cancel? That's not a question that we're ever going to be able to answer. That one, we're always going to defer you to kind of whoever your imaging champion is. So if it's a radiology or cardiology reader, you're going to want to talk to them and kind of have a, discussion per site, per customer, like when do we want to call a case? And obviously it's going to be different depending upon your scanner and your scanner technology. We have seen successful scans at 70 beats per 4, again, depending on the scanner that you have. And again, depending upon the conditions that you have. If you have a heart rate of 80 and the patient is, has a really high BMI, you're going to have not only motion to contend with, but you're also going to have noise to contend with. If it's an irregular heart rate, you're also going to have misalignment to contend with if you're on, a 64 slice scanner. So all of those things kind of are going to play into it. I would also say that you can, if you are a HeartFlow customer, you can reach out to your CT application specialist. They actually have the ability to pull your scorecard data. We can bucketize heart rates, so you can see, how successful are you in heart rates that are under 60 beats per minute, and how successful are you in, the greater than 70 arena. So just, you know, something else that you can do is reach out to them and see, you know, what have you been doing as far as the cases that come to us.
So Amanda, they're adding on to this question and say, so minimal variability may still produce an acceptable scan, even if it's at 70 beats per minute. Is that a fair summary then?
Yeah, I think exactly what Stefanie said. You need to, there's kind of not an actual cutoff. It's really based on the physician, how they like to, because they're the ones reading it essentially. So I would always just double check with them. It's good to have kind of a baseline, a number of, you know, if you can't get below 75 or if you can't get below 80, then you need to call me, kind of thing. And then, because they're going to be the ones reading it, but it does depend on patient condition, patient BMI, what scanner you have. So there's a lot of factors that go into play, but just knowing your protocols and your scanner and your patient. So it's best to just come up with something collaborative with the reading physician.
Yeah, that's great. They do comment that they're running 20-minute windows
Wow.
on their scanner. So that's
quick.
Best in class kind of stuff.
Yeah.
I love to see that. I'm actually going to take the next one just for fun here. It asks if the FFRCT number, so the value you get from an FFRCT, is on the same scale as an invasive FFR measurement. And the quick answer to that is yes, right? FFRCT, the HeartFlow FFRCT analysis, has been validated against invasive FFR in hundreds and hundreds of patients, in thousands of vessels. So as part of our FDA clearance and our ongoing work, that is a fundamental part of what we do to ensure that this information that's available non-invasively is very comparable, if not, you expect it to be a very, very high degree of match to the invasive. And anytime that that's not the case, we HeartFlow go back to try to understand what might have gone wrong and how we can improve on that to ensure that it doesn't happen again. The next part of that question is they say, can we enter FFRCT values into the NCDR PCI registry? So the National Cath Diagnostic Registry, PCI, this is a registry in every cath lab that's hosted by, I think the ACC is behind, owns that, to justify the patient meets acceptable use criteria for PCI. The answer to that is absolutely yes. So FFRCT is recognized comparable to IFR or invasive FFR, and those values can be entered in on that registry. For the person who's asking that question, you can reach out to the HeartFlow team. We certainly have detailed information on how that survey, even what questions that is on the survey where you can enter that information to meet acceptable, appropriate use criteria for an intervention based on having physiologic information on that patient and that stenosis. So hopefully that's helpful. I think this one is specific to a technology. Maybe we'll do this one and maybe one more. We'll see where we are. But it just says something about high res mode. Let me see where it went here. It just says, oh, I may have lost that question. Well, anyway, it was asking something about is high res mode something they can use on moderate patients. Where did that go? Oh, recommended for any moderately sized patient with plaque. That must be a vendor specific setting. I apologize, I'm not familiar with that. So Amanda, is that one you're familiar with?
It's a setting on a scanner, but I would say anything with plaque, I would, if you're submitting it to HeartFlow, it's great to add that sharp recon because we're able to really quantify those luminal boundaries, and it's helpful for our analysts for processing, along with the along with the soft kernel as well.
Yeah. Yeah, Stefanie, I'll go to you, and then I've got a couple I think that I might answer here. Why exactly do the lower heart rate scans provide less artifact?
So when you put your patient on the CT leads, you're measuring their ECG trace. You're using their ECG trace to trigger your X-ray on, and then you're also using it to say where your reconstructions are going to be. You use the R peak to trigger and to measure, which is the peak that's going to go up the highest in that ECG trace. The slower the patient's heart rate, the farther apart your R peaks are going to get. There's a little bit of a quiet time that I like to call it, kind of mid to the end of the R to R cycle. And the slower the heart rate gets, the farther those peaks get apart, and the more quiet time you have. So you have more opportunity for less motion during those quiet times. And motion is the kind of the number one barrier that we have when we're scanning coronary arteries, because we're scanning something that's really, really tiny and it's moving pretty quickly. So lowering the heart rate, again, is going to move your R peaks farther apart. It's going to provide more quiet time and less motion on your images.
Yeah, that's really helpful. So I'm going to take on this one around reimbursement, and what I'm going to say is that I'm not going to answer that here, but we have a whole team of people ready to help with that. The question is, anything to consider as far as getting FFRCT successfully reimbursed from insurance? So what I can say about that is that FFRCT is covered in appropriate patients, and those, what is deemed appropriate, are patients in whom an anatomic stenosis, well, actually just a patient with suspected coronary artery disease that would justify the CT, and when they recognize that there is, an anatomic stenosis that is appropriate to assess whether blood flow is being impacted, that can get sent for FFRCT. The ACC AHA chest pain guideline indicate that that would be an anatomic stenosis between 40 and 90%. And so if one of those is identified, reimbursement across the US from Medicare, most private payers, we're talking 95+% of covered lives, and even many Medicaid programs across the United States are covering this application, this modality, to better assess patients. So if you're in an institution where that is not happening and there are struggles with reimbursement, please reach out to our team. We've got an exceptional team who can provide a very detailed look at what can be done within your unique geography and with the unique payers that are a part of the equation that you're trying to solve. So we're ready to help on that, I think, is the takeaway. And coverage is broad across the US. So I think this will be our last question. So because this one is a tricky one, so I'd love to hear both your thoughts on it. It says, any advice on how to deal with clinicians that are skeptical regarding FFRCT results? So I think that sounds like not just the results, but maybe the technology in and of itself. And obviously clinicians, I don't know if these are readers that they're thinking of, whether radiology or cardiology readers, or maybe the interventional team or the referring physicians. But I guess Amanda and Stefanie, do either of you, and maybe both of you, we could sort of, what do you share when you're first introducing it to help somebody understand why this may need to be part of what they're doing, right?
I would say probably just doing the research, and HeartFlow's done tons of trials and studies, and I would say just digging into those and going through them. They're helpful.
I would say the first thing that I always talk about is the ACC and the AHA chest pain guidelines, and how coronary CTA with FFR was elevated and is a frontline test. And then the other thing that I would say is just to kind of piggyback off of what you said, Michael, is that we have teams to help. So if we have business development representatives that can go out and educate referring communities. If they're referring physicians that you need convincing, or clinicians that need convincing, we also have a med ed team we can, we can work with them to organize, different kind of education. We can have MD peers to come in and help and educate. We're, it's not just the CT apps team, but we have a really full team that can help with that.
Yeah, that's excellent. Well, on behalf of the whole team at HeartFlow, we're grateful for everyone that's here on the line. Thank you for taking the time to join us today to learn about how this technology can impact what you're doing clinically, and especially what your role as a CT technologist is and how you make this possible. We're grateful for the opportunity to continue working with you, and please reach out if there is anything that we can do to help you as you are building your programs and making improvements. And we look forward to that. So thank you all. Have a wonderful day.